Look, can I begin by acknowledging the traditional owners of the land on which we all meet, and that is all over Victoria and perhaps even beyond, and pay my respect to their elders past and present. What a special occasion, an unusual occasion. I guess over the last 2 months we've all become pretty used to doing things in a very different way, and most exclusively meeting over Zoom or in some way over the computer. Very strange times that we're weirdly becoming familiar with. But this is the first time we've held a session like this. Usually we love to meet people face to face and hold lunches and seminars and so on, with a chance to interact, with supporters from all different fronts. On the line, those of you who have supported the organisation for a long period of time in different ways, and we really welcome the opportunity. Those of you who are on the line who have had anything to do with the Burnet in the past will know that we love the opportunity to speak with you. It's quite a privileged opportunity to talk to people who care about what we do but don't live and breathe it every day like we do. But it's especially relevant at the moment. So I hope this online way of doing things works in the interactive way that in person works. And to try to facilitate that, we've taken some questions ahead of time, and also on the chat. For those who don't use Zoom all the time, there's a little chat icon that you can click on, and you can ask questions on there. And both myself and Dr. Ben Coughlin, our head of health security, will try to coalesce those into questions that we can answer at the end, or in the last third of this hour. So please do think of it as interactive, although we're not going to be able to hear from everybody's voice because of, or anybody's voice, I don't think, because of the nature of 100+ people being on the line. So thank you everybody for joining. I know that there's a hunger to do two things. One is to support the Burnet, which is why you all have been joining us over the last decade, in many instances beyond that, and I really appreciate that. The second is just the interest that we all have in learning more about this very strange time we're in, and what the driver is of that, where we're going with this disease, COVID-19, and of course specifically what the Burnet is doing about it. So let's hope we can make some progress there today. To set the scene a little bit, you'll hear a little bit from me by way of introduction, and then I'll introduce three speakers who will speak for a relatively short period of time, but they're three leaders in the Institute who are driving different elements of the Burnet's response. And I'll introduce David Anderson, Margaret Hillard and Leanne Robinson to give their brief presentations after mine, and then we'll take this hopefully 15 to 20 minutes of questions with Ben Coughlin's help. I think the first thing I want to say, though, is that I'd like you to all feel, if you don't already, but by the end of this session, pretty proud of yourselves for your commitment to the Burnet, because it's through that support that we're in the position we're in to respond to COVID-19 in the way we are. You can't just click your fingers and out of nothing provide a response to a mystery disease if you don't have incredibly good infrastructure, physically good infrastructure, more importantly, highly trained people who are ready to go. So, but that's what the Burnet has, the best part of 400 staff, all of whom are suited to addressing this infection. And even though we're only a couple of months in, almost half of the Institute is focused now on addressing COVID-19 in one way, shape or form. And of course, the things that we traditionally address are still very, very important and don't go away. And it might come to that in question time. But just like you to feel proud of creating that infrastructure that's allowing us to hit the ground running across the entire spectrum of what's needed to deal with COVID-19. And I think one thing that COVID-19, if something really new like this demonstrates, is that a research involvement is central. You've got something totally new. You don't know anything about it. We now know that it's caused by a particular virus called SARS-CoV-2. But there are still so many questions. There, of course, were an infinite number of questions from day one. There are still so many questions. It isn't like we have this series of actions that we can magically take, tests that we can do, drugs that we can deliver, interventions that exist. We don't know anything. And so agencies like ours that are research at heart, at the interface of research and directly working with people and communities in providing part of the health infrastructure, are obviously front and centre in the COVID-19 response. And it's especially so for the Burnet, because our background is from the Fairfield Hospital days, for those who remember, and I know many of you on this call do. That was an infectious diseases hospital. I kind of wish we still had it, frankly. And we were born out of that time. When that hospital disbanded some 30 or so years ago, the Burnet Institute became evolved out of that, the research arm of the Fairfield Hospital. So our DNA is infectious diseases, and especially infectious diseases that emerge out of nowhere. HIV being the big story of the time, very different disease to COVID-19, but of course somewhat related. Viral zoonosis, transmitting from animals to humans and actually changing the world. The last big new disease that fundamentally changed the world is HIV, still relevant to this day. So with that sort of infectious diseases background and the second sort of major theme of the Burnet that's run through the last 30 years is how addressing infectious disease in the context of the most vulnerable populations, the most vulnerable communities in our own midst, but also in our region and in the wider world, is our special niche. And dealing with COVID-19 brings those elements together so beautifully. So Burnet hasn't come out of thin air, and it has been so heavily dependent on all the stakeholders and all the supporters, and that includes government, and there's government supporters online. We're totally dependent on that. And so I want you to feel proud that you've created that capacity to respond to COVID-19. The second thing is, of course, I've already flagged, you're going to hear about what we are doing at the moment and intend to do across the spectrum of areas that need to be responded to. And I think I have a slide that can be put up for me, if it's not already put up, to show that. This slide, you should all be able to see now, says our COVID-19 response, this is actually pretty much the response that's needed globally to deal with COVID-19, and we're involved in all elements of this response. And of course, we don't act in any of them on our own. We are part of collaborative networks, especially with government agencies, but with lots of our like-minded partners throughout Australia and throughout the world. So you can see these sort of 6 key areas, some very visible. We've all heard about the need for a vaccine that, you know, until we have a vaccine or maybe a therapeutic drug or a combination of both, we won't have a magical way out of COVID-19. You will have all heard that right from the beginning. Burnet's heavily involved in both of these areas. Behind the scenes, we're really involved in advocacy. I mean, advocacy sounds a bit adversarial, but more we're involved in partnership with our chief medical officers and chief health officers and our state and federal partners more generally in together, putting our heads together and coming up with ways to deal with this emergency in the best way we can. You're going to hear, especially in a moment, about our focus on diagnostics and why that's just so important. And there's diagnostics and diagnostics. We know that you can go into the hospital now and you can get a nasal swab and you can be diagnosed as either have or having not had, as either having or not having at the moment an active infection with COVID-19. But what other sort of diagnostics are there, and what's really important? You're going to hear about that. It's an area of core business for the Burnet, as I think most of you will appreciate. You're also going to hear about our public health research and public health activities. Now, that sounds a lot vaguer than antivirals or vaccines, but actually that is the intervention tool that we have at the moment. It's the only intervention tool we have at the moment to not have COVID-19 be a problem in the community. We have to stop people getting infected, and we have to stop them getting infected without an antiviral drug or without a vaccine. So that's where these words of physical distancing, of quarantine, of social isolation come from, and of the tools to get there: diagnostic testing, tracking and tracing those who are in contact with people who are positive and putting them into quarantine. So that, in a nutshell, is the public health intervention. How can we make that better? How can we optimize how that works? And that's a significant focus of what Margaret Hillard is going to talk to you about. And then, of course, we're involved in what's happening beyond Australia's borders, but particularly in our priority countries of Papua New Guinea and Myanmar. And you will hear from Associate Professor Leanne Robinson about a very scaled up effort in Papua New Guinea to support that country. And of course, we care very much about those countries because they're our partners, and we want to see, especially those countries that don't have the same health system and wealth as Australia, not suffer from COVID-19 simply because of those regions. But it's also relevant for Australia. COVID-19 is a global disease. It'll never be dealt with, in inverted commas, until it's dealt with from everywhere. So we can't just have an Australian-based focus for it. So, and then I hope at the end you're going to be inspired by what you see to dig deep, basically, to support our Emergency Response Fund, as many of you already have. We are well on our way. We have an internal target to keep this work going. We're about halfway toward that target, and we would greatly appreciate support to finish the job there. But I'll now hand to Professor Margaret Hillard, also Deputy Director of the Burnet, to tell you about our public health activities, about the one intervention that we actually do have, and why, you know, it's perhaps far more neglected than it should be, given it's the only tool we have and the only tool we'll have for quite some time yet. Margaret. You're on mute. We can't hear you, Margaret.
No, I'm not talking because I'm trying to be, I need to be unmuted by the host, Brendan. I didn't mute myself.
There you go. We can hear you now.
Yes, Rob happily muted me rather than me muting me, so I didn't have control of. Thank you. First of all, can I thank everybody for giving up their time today? It's really great to see so many people here. What I'm going to talk about is the optimised study, but really want to emphasise, as Brendan was saying, the actual importance of the public health response to this. And what the optimised study is about is optimising isolation, quarantine and physical distancing. And it's a partnership led by the Burnet Institute and the Mortality Rate Institute, but with collaborators across the state and probably also across Australia. And it's supported by the Victorian State Government, and also the Macquarie Group Foundation has made a really generous donation to that to this work, and I thank them for that, of $1 million. So I just wanted to talk about how we need to think about if we want to eliminate an infection. Brendan's touched on this, but in a way, if you think about it, with the Burnet, we do a lot of work around disease elimination, and a lot of my work, a number of them you'll know, is really focusing on how do we eliminate hepatitis C, hepatitis B, and HIV. And there's some key things we know that need to happen if you want to successfully get rid of something. It needs to be a broad, multidisciplinary approach. You need diagnostics, you need therapeutics, a cure, and you need a vaccine. But as well, you need a really strong public health response. And then, as you'll see on the outside of this circle, a whole series of things that need to be worked together to inform how actually do you implement. Because even if you get a vaccine, the discovery of a vaccine is wonderful, but it's still a public health thing to actually make sure it gets rolled out. The discovery of a drug that cures, and my work in hepatitis C clearly shows this. We've got wonderful drugs to cure people, but the challenge is to get it into the community and to make sure the affected community gets it. And in particular, the poor and vulnerable communities, nobody misses out. Same with diagnostics. You can have fabulous diagnostics. We don't have one yet, but David will get us one. But the trick is as well, how do we actually make sure that that diagnostic test gets to the right people at the right time? How do we actually have it happen? So these are things that we spend a lot of time thinking about. But it's really important that we understand that over the next 6 to 12 months, that we do not have a vaccine and we do not have a drug, and there will be none. And there will be no vaccine and there will be no cure in the next 6 to 12 months. And the current diagnostics are limited but improving. So what is basically our silver bullet is not those things, but a strong public health response and a really careful, cohesive response where there is a lot of thought goes into it. What we're asking really is for behaviour change, or what we would say is, people talk about community compliance with the government's control measures. It's absolutely critical. And in a way, what we're saying is behaviour change is our current vaccine. It's the current thing that will help us prevent new cases and ensure that we have, if we do have cases, they're quickly traced and the like. So we need to optimise the community's ability to comply with what is being asked of them. And people often complain about somebody not doing what they're asked or not staying at home and all of these things. And this is what we call a straight up thing around behaviour change. For somebody to do something, they number one need to be aware of what is required of them. That's really important. Are we getting the messages out in a way that people recognise them? Are people from culturally and linguistically diverse communities actually getting messages in a way that they can, in the right language that they can read? Does somebody actually have the internet? If you think about, say, people being released from prison, we do a lot of work with prisoners. Are they actually having access to the internet? Are they actually able to get the messages? If you're living in rural and remote communities, is the internet actually working as it should? The next thing is somebody actually has to accept the control measures. And that is that you actually internally and externally agree. At an individual level, I agree that I need to stay home. And at a community level, that you also have this agreement with government, with everybody about it. So that's a really key thing around how we think about work. And the next thing, is it feasible? It's all very well to say, yes, I know, and yes, I agree, but is it feasible for me to do that? Is it feasible for me to get that test? Do I have to wait 3 hours and I can't do that? Do I have small children? What are the things that impact on my ability to do what is being asked of me? And the big issue is we actually don't have this information. So we urgently need quality information about what's happening in the community to help them cooperate with whatever it is that the government is requesting of them. This will improve the precision of the government's response to both reduce infection and reduce, also really importantly, the unintended consequences of the control measures. The control measures had to come in a hurry, and they're kind of quite diverse and just general. But as we release from the current situation, where we want to have maximum benefit for the community more broadly in terms of economics, in terms of health and well-being, but we don't want a recurrence of disease, this requires much, much more precision. And a lot of our work is around what's the information we need to get and how do we help the government have that precision, and hence the optimised study. And what the optimised study is a highly innovative, multidisciplinary research platform. It's more than one particular study or piece of work. And the aim is to provide the government with timely and high quality information to help them make informed, precise and impactful policy changes. So it's a combination of things where we will collect strategic information by following two cohorts of people, some who've had disease and some of the general community, and look at them and their social networks, and trying to determine what factors help people cooperate with the government to be compliant, assess the unintended consequences of things, so that, because we know that if there's unintended consequences, that will make it that you are far less likely to be able to be compliant. Identify particular vulnerable populations and how do we help support them. And if you think about it, say things like Ramadan is happening at the moment. And if you think of, so Ramadan is impacting on a group of a population where they will need to have clear messages about what needs to happen to make sure that people keep safe. Often from, so there's different places and times when you'll need different messages. And this issue of how do we actually look at social contacts and mixing, and I'll show you in a moment a piece of work where that's a really important thing. And all of this needs to feed very quickly into national policies and practices about what's going on. So it's not just a matter of us keeping this information, but the whole study is designed to each week to 2 weeks give the government a really quick and brief report, and I'll show you an example of that in a moment. So it's a very interactive piece. It also involves modelling, social network modelling, and qualitative research of talking to people in much more detail about what's going on in their lives. So it's quite a complex piece of work involving people from different organisations across the state to help inform the government's response and bring in this precision that's needed.
Thanks so much, Margaret. And of course, just emphasising that as I've done now 3 times, but there is, for the foreseeable future, even with the pace at which vaccines and drugs are being developed, you know, realistically 6 months, 12 months to 18 months before those are online and available, and even then a public health response will still be needed. So this is what we've got, and the sort of work Margaret described is the only way that public health response can be optimised and used effectively. So thanks for that, Margaret, and we'll come to questions in a moment. Now to Associate Professor Leanne Robinson, who's the technical lead of our Papua New Guinea program, is a very large part of the Burnet. Possibly a quarter to a third of the Burnet now focuses on work in or related to Papua New Guinea, so it's a very major part. And we're lucky to be able to hear from Leanne this afternoon on what's happening with respect to COVID-19 there and Burnet's involvement. Leanne.
Thanks very much, Brendan. And yeah, as Brendan says, and as many of you are aware, Burnet has a really large international health program, and particularly in Papua New Guinea, we've been working together with our local partners for over 30 years to achieve better health outcomes for all Papua New Guineans. With a fragile and under-resourced health system, high rates of infectious disease, including malaria, drug-resistant tuberculosis, drug-resistant HIV, as well as an increasing burden of non-communicable diseases, most notably diabetes and heart disease, PNG's population of more than 8 million people is already vulnerable. And so together with our partners in PNG, we've been incredibly concerned about the impact that COVID-19 and associated COVID-19 measures will have on the population. In response to the global COVID-19 pandemic, the PNG government introduced a state of emergency 2 months ago, with an immediate 14-day lockdown that restricted all domestic travel, both within and between provinces, and closed schools, markets and businesses, similar to what we've all experienced here in Australia, but probably with quite different impacts in terms of the ability with which communities can respond to such a dramatic change in lifestyle and livelihoods. Whilst the state of emergency will be in place until at least the 2nd of June, restrictions have now started to ease in most provinces, and some domestic flights have recommenced, while the international borders still remain closed. Unlike in many other settings around the world, the epidemic has not yet escalated in PNG, and there are currently only been 8 mild cases of COVID-19 reported over the past 4 months without any deaths. So this is an excellent outcome so far in terms of where things are going in PNG. There's no evidence of infection clusters or community transmission. But that said, 8 of the cases that have been reported so far have been spread right across the country in 5 different provinces, from the far west, where PNG borders, West Papua, Indonesia, to the far east in East New Britain, where we have a strong program of work in collaboration with the Provincial Health Authority. A range of factors may be contributing to the difference between the PNG experience and what we have seen in other populations around the world, including rates of testing, population age structure, population density, mobility patterns, and climate. However, I think it's fair to say the situation remains poorly understood, and there is a really concerted effort by the PNG government and its partners to scale up the testing being conducted. And this has substantial support from the Australian government, with the recent provision of more than 10,000 GeneXpert cartridges to support this scale up. Despite the ongoing lockdown restricting cross-border movement, there is a high level of concern about the vulnerability of provinces bordering West Papua, Indonesia. This includes locations where several of our ongoing programs are based and have been heavily impacted by the situation. And there is increasing recognition globally, and particularly in relation to PNG, of the impact that COVID-19 related restrictions and associated stigma on the provision of essential health services, vulnerable people and livelihoods. With more than 70 locally employed staff operating across 6 sites and long-term partnerships with the national and provincial health authorities, the PNG Institute of Medical Research and the Central Public Health Laboratory, Burnet is currently actively engaged and working with our partners to identify the most impactful way we can support the PNG health authorities in their COVID-19 response. Our East New Britain, Daru and West Sepik based teams are already directly supporting the Provincial Health Authority with health promotion, community education and preparedness activities. A nationwide program of clinical training on guidelines for COVID-19 is underway. This training covers infection, prevention and control, integration and continuation of other services, and clinical care and management of COVID-19. Burnet is also planning to provide virtual training on COVID-19 related areas to clinical staff at provincial hospitals, district hospitals and referral hospitals right across PNG. Strive PNG, a collaborative program between Burnet, National Department of Health, PNG Institute of Medical Research, Central Public Health Laboratory and University of Papua New Guinea, is supporting COVID-19 diagnostic testing and surveillance. The Strive program has pivoted its real-time vector-borne disease fever sentinel surveillance network towards COVID-19 in order to provide real-time data to government authorities for decision making. This map is an example of some of the work we are doing. It shows the number of fever cases in a catchment around a health facility on the outskirts of Lae on the north coast of PNG. And it has interactive dashboards that allow health officials in the area and at the national level to drill down into the data from particular areas of the community in more detail. Communities with a higher burden of acute respiratory illness could, for example, be targeted for additional testing. Tools like this also help to streamline the roles of overburdened frontline health workers to ensure that important data is transferred to relevant health authorities in a timely manner. Many of the questions being explored through the optimised program that Margaret just outlined may have a high level of applicability to address issues in PNG, and in partnership with the PNG Institute of Medical Research, we'll certainly be supporting a program of operational research to try and understand why the epidemic is not following similar characteristics as other settings. Importantly, I want to finish by emphasising that the impacts on and interruption to the delivery of primary health services in PNG is likely to have a substantial negative impact on the health and well-being of the population. Primary health care, routine vaccination, disease control programs, maternal and child health services, all of which many of our programs are actively supporting, must continue to be supported. Integrating COVID-19 preparedness, surveillance and response activities into existing policies and plans is really important in order to minimise the impact on essential services and the downstream consequences on vulnerable populations. Thanks very much.
Thanks so much, Leanne. And this session is now open for questions, and we have quite a few. But because we've got Leanne on the line and it's fresh in our minds, I'm just going to start there, Leanne, just with what you touched on at the end about, you know, there's COVID-19 on the one hand, there's all the other health issues on the other hand. And I just wondered, I know I'm asking you to speculate here, but what do you worry about the most? Is it COVID-19 getting out of control, which would obviously be devastating for a place like PNG? Or is it all of those other issues that are important to PNG anyway, like malaria that both you and I work on, or, you know, that at least kept under some semblance of control, and we worry so much about a broken health system, meaning they come back with a vengeance. I mean, are they just both equally important, or is one really keeping you up at night?
I would say it's the combination, Brendan. Really, it's about how can we find a way to ensure that we do address what is a really serious health issue of COVID-19, but in a way that doesn't fracture health programs that are already in place and the delivery of essential health services. Because I think there has been some modelling done that shows that if these programs are interrupted, then we can really expect a devastating toll on the health of the population that could far outweigh the toll that COVID-19 may have. So it's a combination.
Yeah, thanks for that. And of course, what's prompted for those who have just got a sense, I guess, from what I just said, but while both Leanne and I work on many things, our own personal specialty interest is malaria. And it's often said that whatever causes a health breakdown interruption in an already poor tropical country, whatever it is, whether it's economic disruption or in this case, another infectious disease, what people are going to suffer from most is malaria. Doesn't matter what the other issue is. So you know that, and we know that you can go wider than that, especially maternal and child health concerns more broadly, and so on. So we stress a lot about that, as well, of course, as Leanne's nicely said, the potential. You look at what's happening in the UK and the US and Spain and Italy and Sweden and so on, with the devastation, and that's with good health systems, you know, so we can see why we're so anxious about places with, you know, health systems that only 1/100th of the capability of any of those. It's a very scary situation. But I think the science is not in yet. One thing that's really interesting about Leanne's talk is that, and it's being replicated in other poorer countries, especially in Africa, is that we're not yet seeing a large problem. Are we just too early? Are we not diagnosing them? Or is there something else going on in this immune-driven disease that leads to less severe illness? We don't know the answer. I'm very much hoping it's the latter. We do not know the answer to that, but science is going to hopefully tell us. Now, Ben Coghlan has been feverishly writing answers to people's questions, and I'm going to throw to one that to Ben to deal with this issue of herd immunity that's come up a number of times. What is all that about? Clearly, Australia is not going down that path. The Prime Minister himself just said a week ago that he now considers this a totally discredited idea. And I wonder if Ben and then maybe Margaret could comment on this idea of herd immunity and why we're still hearing about it.
Thanks,
Ben,
Ben.
are you there?
Yep. Can you hear me?
Yep.
Yeah. So I guess early on, people thought that this was going to be a very, very challenging disease to control because it was looked quite early on to be spread before people were developing symptoms, and then even those who were infected but never developed symptoms. So those type of things are very hard to control at borders if you're just doing fever assessments or questionnaires for symptoms. And the UK, partly based on modelling, had thought early on that if they could effectively isolate vulnerable groups who, if they got infected, were more likely to have severe disease, but allow the disease to run through the community and to infect those younger groups who are unlikely to have severe disease and wouldn't end up in hospital, that they could establish enough immunity. This assumes that if you get infected, you do have immunity and can't be reinfected, either for life or for a certain number of years. If you had enough of those people infected in the community, then you could allow people out from their quarantine, those vulnerable groups, and their chance of coming across the disease was likely to be less because most people would be immune to the disease in the community. So things didn't pan out very well for the UK, and their subsequent models showed that that was probably a bad idea, and their actual experience of their health system being overwhelmed and having, one of the highest case fatality, the highest case fatality rate in the world, showed that was not a wise strategy at all for controlling the disease and averting deaths. So traditionally, we think more of herd immunity in terms of the number of people or the proportion of the population we need to vaccinate to stop the disease spreading if it's introduced into our community. So I think the concept of herd immunity now has shifted to one in which we will embrace when we have an effective vaccine and can deliver that to enough of the population to interrupt disease transmission, just like we do for measles, for instance. So measles comes into our community. We may have small outbreaks, particularly amongst groups that haven't been vaccinated, but typically it doesn't spread far and wide because most people have been vaccinated and are immune to the disease. Thanks, Brendan.
My other comment on it, Brendan, is and I think Anthony Fauci was sort of saying this the other day, is this concept that we think we know everything about this at the moment and we don't. So sort of a herd immunity is predicated on the fact that if it runs through certain parts of the population, they won't be particularly badly impacted on it because they're not seeming to have a lot of symptoms, so they'll be all right, and then we'll get this protection. But I think we've got to remember this is always curves, and that's going, well, are we really comfortable to go, although the mortality rate in somebody who's between 40 to 50 is not as high as the mortality rate or the case fatality rate in somebody who's above 70, it's still significant if you think about it at a population level. As well, there are things we do not know yet about the post component of having had the infection, and I think we will discover more and more about this when we. So I think.
And Margaret, we had a specific question or two about that. What do we know about other pathologies at the moment? Do you just recover and you're back to 100% normal, or do we not know that?
There's growing concern. So I think what we've got to say is there's lots we do not know. And I think we have to start with the assumption that there will be many things that we will learn over this next 3, 6, 12, 2 years, 5 years kind of thing. But increasingly, there's a growing awareness that because of the intense sort of immune response that happens, particularly in that second week of infection, that this is likely and may well likely have, for some people, not everybody, long-term impacts on their health. And this might vary between people. And it's often when we have these things that it's depending on what somebody's underlying background illness, if they have one, is as to what gets exacerbated in terms of either kidney disease or this disease or that. But also, you know, and people will have been reading about these unusual infections and this question about whether or not in children, this immunological response, a Kawasaki-like disease. So there are, I think we have to say there are many unknowns. And so we have to be really careful about then saying, oh, we're just going to happily let a disease run through the community as if we really know exactly what's happening. And as Ben said, herd immunity is really being developed around the concept of a vaccine, because we know in terms of looking at diseases where you don't have vaccines, they come in and out of the population and cause tremendous illness when you don't have that situation. So in countries where when you get measles come back into it, you get significant illness, morbidity, mortality, and death. So you can't just afford to have these diseases. I think we've forgotten sweeping back through populations. It's just not a good idea overall.
No, and no, I totally agree with that. I saw a piece on Spain yesterday that was one of those toying with the idea of a herd immunity approach, and then it's just kind of dawned on them that even just with all those other considerations that Margaret and Ben have just said, you know, there's a high death rate anyway. You have all of these unknowns. It's also actually very hard to get there. So they've had this major problem. I think around 30,000 deaths now, overwhelmed health system. It's still raging, and they're only at 5% coverage. And they want the, you know, let's assume for a moment that we know what we're talking about with immunity, but we don't. They're saying we want 60 or 70% of the people immune. They're miles away from that. It's not even close to reaching it. And look at the suffering they've already had. So it's a totally flawed, in every way, idea.
To me, it's absolute hubris to think. It's that typical thing that we think of as humans, that we get to control situations. And I think this is giving us a really clear reminder that we don't, and that we have to go back to some basic principles to protect people. And that, it's not going to be that we get to control how this flows through the population, because we don't know enough about it.
And so just before moving back to Ben for the next question, and Ben, I'll leave you to tell me what that question is. We're very lucky, obviously, in Australia that we didn't go down that path. Both the state and federal governments decided very early on, when our numbers were very, very low, that they weren't going to risk that. And so that's why we went into this society sort of lockdown, shutdown type mentality, where a lot of activities were closed off very quickly, that we're now emerging from a little bit in a very steady way. So we're extremely fortunate that they made that decision when they did, and no doubt saved thousands of lives in Australia with what we now know happened in the countries I mentioned. Ben, what is a big issue of the moment? Through the questions.
There's a question that I haven't had a chance to reply to, really about a concern of young people in Australia. Are they adhering to the current measures? So are they staying at home? Are they avoiding big gatherings? Are they practicing good physical distancing and hand hygiene? There's interesting cases from overseas where, you know, in countries that have had successful control, like South Korea, where there's been a resurgence amongst young people as the drivers for infection. So in South Korea, it was nightclubs, actually, which seems to be a major cluster which has spread out to the wider community. So I might flip that to Margaret to actually think about how we're looking at that and trying to optimise the control across the community, including for those groups who may feel no sense of risk for disease, but yet seem to be important in the overall transmission in our community.
Yeah. So a couple of things. The optimised study will include young people, because I think if you think about disease transmission, you can't just exclude a group because they don't get obvious symptoms. So I think it's really important to look at that. Some of the big data that's being followed has shown to date that overall there has been pretty good cooperation or compliance with what the government regulations are, but it's far from perfect. So I think that's an important thing. The other thing I'd like to note is Megan Lim, who heads a body of research at the Burnet around young people and risk, is doing some specific work on COVID with young people to try and again get a sense of what they're doing. And again, I think it's really important that if we all just think about ourselves, and I always say this when we talk about compliance or cooperation, most people on this call will have got a speeding fine at some stage, although we all know the speed limit. And we all had an excuse for why we sped at that particular moment. Always a good excuse. Didn't see so this, I was here, da, da, da. We always have a very good reason. So when we want to say to somebody, you're not complying with the government regulations as a young person or a middle-aged person or this person, we've just got to remember that we've probably all not fully followed, with, there might be an exception on this call, the full requests. And we'll have had a really good reason for why we did it that day. And we've just got to think that that's exactly what's going through the mind of most people in the community. There will be moments when people will struggle to fully cooperate, comply. And what we've got to do is go, why? And then if this is a consistent problem through a particular group of population, say like young people, or say like people that want to go to church and it's really, really important for them. Say for people who have a care responsibility, for lots of reasons, that somebody might be literally, the nature of their work means that they will just not be able to feed the family. We've got to then say, how do we assist them? Or a mental health reason. How do we assist that person to mostly comply? And so if we get, and the models would suggest, over 70 to 80% compliance or cooperation, then we do very well. So it doesn't have to be perfect, but it has to be that 70 to 100% in that range. So our job is to say, if you're not doing what we would like you to be doing, is there a good reason for that, and how do we help you do that? There'll be always a few percentage that never do what they're asked, but mostly people want to be helpful, and we've got to help people be helpful. And that's what Optimise and a number of other pieces of work are about, is how do we help people to be doing what they want to do, to comply.
And Margaret and Ben, can I extend this idea? So we've moved out, we're moving out in Australia and in much of the world out of this lockdown type, just gently, gradually, but we're opening up. And we're doing so on the basis that we have a better capacity now to track virus in the community. We had no capacity to track virus in the community 4 to 6 weeks ago, just at the border. Now we have a better track in the community. But the community isn't one community, of course. There are many of them. Those of you who have followed this a bit internationally might have heard of the Singapore story, a country that was initially remarkably successful. They had fantastic community containment. They've lived with SARS before. They've learnt lessons of a previous similar infection. But they had a blind spot or two, communities that they've forgotten about. And in those communities, the migrant workers in particular, the virus came back with a vengeance, and it's a major problem now for Singapore. How do we tackle that, Margaret? We have our own vulnerable communities and potential blind spots.
I think, so first of all, we have to recognise it and go, as again, it gets back to this, it's not somebody's fault, it's just that their circumstances make it's really difficult. Now, I think the seed to meat outbreak is a really nice example. If we have a look at that, outbreak in a meatworks, which has been, be really interesting to look. It took us 6 to 8 weeks to be able to identify the cluster. So we've got to be really mindful about this.
The delay.
High proportion of those people were from KEL population. So culturally and linguistically diverse backgrounds. So may have not got all of the messages. As well, socioeconomic situation where they're highly casualised workforce, they need to go to work. They weren't going to get a government benefit. So you can't sort of say, oh, you should have stayed at home if you're actually got no money. So if you're a casualised workforce where you're not fitting into the government kind of regime of having been in that particular job for 12 months, hence you get it, then you will go to work, even if you have mild symptoms. And you could say, well, you shouldn't, but then you're going to say, well, how do I feed my family? How do I pay my rent? How do I do these things? So we've got to be looking at all of those places where, again, although somebody might want to cooperate, life circumstances makes it difficult. If you live in a boarding house, because and this is the kind of places where there is a bathroom in the corridor, like one bathroom to the whole corridor of a group of people who have, potentially poor hygiene because they can't afford to buy all the things that we would say they should have. All of these things, they're vulnerable. If you think about prisoners, very, very vulnerable. So it's circumstances where people might be trying to comply, but actually are unable to.
Now, I have a very interesting question here that kind of in a way relates to the anti-vaxxer movement. But this question is, I live in a somewhat alternative town where a cohort vehemently denies even the existence of the virus. Are these communities a concern, Ben and Margaret?
I think potentially. I think what Margaret's getting at is that if we probably get enough of the community cooperating, adhering to these very simple public health measures in practice, they sound simple, but actually continuing to do them for the long haul and actually adjusting how we do these things in the long term is going to be a real challenge. So I think we do need to keep a handle on what people are thinking, what people are doing, and understanding how we can influence things. So most countries have applied exactly the same public health measures to control the disease, and yet there's been, vastly different outcomes. The socio-cultural dimensions of disease transmission and control really, are at the heart of trying to do a good job here in Australia, particularly as we look to release restrictions. So look, they can be a major source of re-emergence of disease. So the meat workers, if you look at that, close to 1 in 20 of all cases in the US is attributed to an abattoir, a meat worker. So they are a particularly vulnerable group who have to go to work. And if we're not thinking about that element in terms of our control, we're going to miss it, either through surveillance or, wider socioeconomic measures to make sure people are able to comply with things. They may want to, but they may not be able to.
No, thanks, Ben. Oh, Margaret?
So Brendan, I think the way I like to think of things is that you've got the individual situation and you've got a population level. So at an individual situation, if you've got a town that's just refusing to in any way engage, like an area that or a community that's engaging and thinking that this is true, real, or the like. At an individual level, if you're coming in there with disease, it's going to transmit and it's going to be an issue and you need to follow it up, or you might be at risk and you're wishing everybody would be sensible. But at a population level, if you say, that's only a very small percentage of the population. And it's a bit like, say, somebody who refuses to have a vaccine. Those true vaccine refusers are often only a small percentage. And what the rest of it is that causes us to have disease in the community is a group of people where they sort of maybe a bit ambivalent and we make it really difficult for them to get their child vaccinated. So the trick is not to say, you're this, you're that, but to say, how do we make this easier for you? How do we help you comply? It's the same with this. You'll always have a small group who are very resistant. But if over 90% of us are engaged and able to do what is being asked of us most of the time, what I'd go a 90-90-90 rule, then we will be successful at keeping things under control. But you just have to help us be the 90.
Thanks. I'm going to, I know we're 10 minutes over time, so I'm just going to take one more question and I'm going to ask David Anderson to answer it. It really relates to access. So these fancy interventions are going to come. The question specifically is about a vaccine, David. A vaccine comes along, maybe it's a great drug, maybe it's even tests, but tests that even your tests are going to cost money. What are some of the, is it just the rich countries that are going to get it? Are they going to get it way in advance of the poor countries? How, and is there anything we can do to help that?
Well, certainly in terms of what we can do, it's largely limited to advocacy for things like vaccines and antiviral drugs where we're unlikely to own any of the intellectual property. But we hope that the lessons learnt in responding to the HIV crisis over the last 35 years will actually make a big difference now. many of our supporters have been supporters since the earliest days of the Burnet and responding to the HIV epidemic. And many of you will be aware that we had the access to good antiviral drugs for HIV for many, many years in Western countries before they were available at affordable prices in the developing countries that needed it most. And one of the mechanisms that ultimately made that happen is an organisation or a function, I suppose, I'm not sure of the right word, called the Medicines Patent Pool, run by Unitaid out of Geneva, where they event governments and lobbyists and certainly Burnet and supporters were part of that too, convinced the big drug companies that rather than giving away their intellectual property, they do have to make a profit, they should put the intellectual property into this medicines patent pool, and then the Unitaid organisation licensed it to manufacturers all around the world so that they could, Indian companies in particular, now supply drugs into all of Africa and Asia at very low costs. And that has supported a complete change in how we manage HIV. Very importantly, about a month ago, Unitaid announced that the medicines patent pool would immediately expand its remit to cover everything to do with COVID-19, diagnostics, drugs and vaccines. And as you know, Brendan, because we've had this discussion, the Burnet has already committed that our intellectual property will be made available through the medicines patent pool because we think we have a really important innovation. We can't supply the whole world, no matter how many partners we may have directly. So it's important that we lead from the front in that as part of our advocacy as well. But I'm fairly confident that the vaccine companies in particular will take the same view, that it's just too important.
Ben, do you have anything to add on that point? I mean, I particularly note that it's interesting to see who's driving development of some of these very expensive development processes. To make a vaccine is incredibly expensive in the development pathway. But it's not just private companies making that investment. It's a very much public enterprises, governments and governments pooling their resources in ways that are very powerful to drive not just the development of vaccine, but to ensure access of the product. And so these are really interesting mechanisms that have been developed over the last decade or so that are being applied to COVID.
Yeah, I think there'll be tremendous pressure to provide these things, at an affordable cost to everywhere. I think everyone realizes that, control of this disease, it came out of, a single province of China, but quickly spread globally. And everyone realizes that, absolute control on a global level, if that is even possible, will rely on getting the vaccine out there once we have one. However, I think, we're in a bit of a period where national lines are being drawn. Already there is discussion about who will get any effective vaccine first, which comes down to which government is providing the bulk of the funding, even if the manufacturing capacity is offshore for that.
Yeah.
So I think this is, I think David's optimism is probably accurate, but I think at the same time there is enough sort of geopolitics being played that countries really are saying, me first, on the back of Trump and the back of China. So I do have a worry that, some of the countries where we work may not get a vaccine for some time. And if the disease plays out badly in those settings, there could be, a lot of deaths that we have not averted as quickly as we could. So I think advocacy is really important and we can play a role in that.
Thanks so much. A great and very, very important question. What's the point of these things if everyone doesn't have access to them and access fast and in an affordable way? So, look, thank you, everybody. I realise I've gone a bit over time and many people have commitments. you've heard about three important areas of activity of the Burnet. You haven't heard about a lot else. We're very involved in vaccine development, for example, especially through our contract research company, 360 Biolabs, who are doing a lot of work in this space in partnership with very serious vaccine developers. And you'll see much of that in the news in the coming weeks and months as an example. A lot of upstream research too. We've talked a bit about why COVID-19 is a particularly worse problem in older people. Not every disease is like that. The influenza pandemic of 1918 was a particular problem of teenagers actually and young people. So there are reasons for this, and we don't know what they are. We have some ideas. There's research in that space going on. All sorts of other therapeutic studies happening, especially with antibodies as therapies, not just detecting antibodies for diagnostics, as David has said. So we've given you a flavour of important projects, but there's much else that we and our partners do. And I hope that that's been an inspiring session to have you continue to support the Burnet, but particularly to do what you can now to keep our COVID-19 research going and in fact accelerate some of the innovations and the research that you've seen today. It's really wonderful to see you all. It's always an absolute privilege to have your attention for any period of time, and today is no exception. And I look forward, on behalf of all of us at the Burnet, to seeing you again as soon as possible, because things are advancing so quickly. We'll have a lot more to say, even in a month or two's time. Things will have advanced so much that I think it'll be worth speaking again. So thank you all very, very much.